Good afternoon, everybody. I'm Margarita Birnbaum, and I am the Health Equity Core Topic Leader for the AHCJ. Thank you for making time to be here today. This webinar is one in a series of topic-specific training opportunities to help health journalists find out what's the latest information in a particular topic, such as insurance, health equity, medical studies, infectious diseases, and to help them give you story ideas or story resources that you can use in your work. Today, we are going to look at all the great data available in the Congressional District Health dashboard. And for that, we have Samantha Breslin, who is the senior project lead on that. And I thought I'd give you a little bit of background on Samantha. She has experience in nonprofit management and public policy. She has a master's in public administration, and she's been working on a similar dashboard for a long time, the city health dashboard, when you can type in the city you're in and you can get all kinds of good information on cardiovascular disease rates and breast cancer rates and unemployment rates. So it covers social determinants of health as well as health-related topics. And today's data sets are going to include firearm suicides, high blood pressure rates, low birth rates, and opioid overdoses, unemployment, and again, other social determinants of health by congressional district. And Samantha's going to tell you where the data's come from, how far it goes, and she's going to share ideas of how you can use it and how other entities are using this data. Cities, nonprofits, states, and public agencies are coming to these dashboards that she has developed with her team at NYU, and I forgot to say that. So Samantha, thank you for being here today, and please put your questions in the Q&A field, not the chat, and we will be tracking those questions. And please fire away with whatever you need or want in terms of information, and Samantha will address them. So thanks for being here again, and take it away.
Great. Thank you so much, Margarita. And thank you to AHCJ for having us today. We're really excited to talk about just how the Congressional District Health Dashboard can be a useful and powerful tool in the journalism space, especially for the folks on this call who focus on healthcare and health equity and all of the stuff that we care so much about. So I will just share my screen. Give me 1 second. Okay. Margarita, can you see my screen?
Yes, ma'am, I can.
Great. So, why is this Congressional District Health Dashboard? Why are we here? Why did we create this tool? And the answer to that is really because until recently, until this year when we launched the tool in January, there wasn't any nonpartisan, rigorous data for districts that was focused and targeted towards not only your standard measures of health, but also the social determinants of health, the factors that shape health and health equity. And those data sets that maybe existed were not widely available or accessible to a broad range of audiences. And so our goal with this tool is to provide that granular data and make sure that it's not only unbiased, which is extremely important to us, but it's straightforward, it's easy to understand, easy to access, and we want it to, help our users inform and catalyze priority setting. So, at the tool, we are an academic institution. We sit within NYU School of Medicine, so we understand the power of data and we love data. But we also know, we're not naive to know that data on its own can't change policy. It can't move the needle on its own. It can't do all of these things that we sometimes want it to do. But it is a really important ingredient, and it's an important starting point. And so data is really powerful in that it can help illuminate challenges and assets in communities that may have otherwise be hidden. It can also inform effective policy solutions. What might work in one community might not work in another community, and data can help us kind of parse that out. And then finally, and quite importantly, as we go into the upcoming election cycle, data can be used to hold our leaders accountable. Are our elected officials living up to their commitments and responsibilities? And how can we let them know how we feel? And when we created this tool, as Margarita mentioned, a lot of the development that we had kind of undergone for this was building off of the work that we've done, both developing and managing our sister website, the City Health Dashboard, which focuses on cities as opposed to districts. And so that site is 5 years old this year. So we've spent a lot of time, honing in on messaging, honing in on our communication strategy, honing in on our metrics, all of that stuff. And so we wanted to apply those lessons and those best practices for this tool. And so in terms of who our audience is for the Congressional District Health Dashboard, it's really broad. And that's the strength of this tool. We want elected officials, but also their staff, advocacy organizations, community organizations, residents, journalists, researchers, the media, all of these people to find value on our site. We want our site to be accessible to a wide range of audiences, regardless of where they live, the size of their district, their political affiliation, their expertise in data. We want everyone to be able to find value. And so the website is just congressionaldistricthealthdashboard.org. I know it's a mouthful. It's pretty long, but hopefully, once you go on once, you remember it, you bookmark it for the next time. But we were developed, like I said, we launched in January of this year, so we're very new. And our team sits out of the Department of Population Health at NYU School of Medicine, but we were developed in very, very close partnership with the Robert Wood Johnson Foundation, as well as our bridging partners, the Bipartisan Policy Center, as well as the Center on Budget and Policy Priorities. These are both nonpartisan organizations who work pretty closely with folks on the Hill, do a lot of legislative research, and that feedback and those perspectives are really essential in helping us, develop a tool that resonated across districts and across states. And you can see on this slide a whole list of our measures. We have over 36 measures on our site, so there's a lot of information on this slide. But our measures range across 5 different domains: health outcomes, social and economic factors, health behaviors, physical environment, and measures related to clinical care. So it's a really broad 360-degree view of health and those social determinants of health. And all of the measures listed here that have an asterisk next to them, we also have demographic breakdowns available. So either by age, race, ethnicity, or sex when that data is available from the data source. And I do want to just mention that all of our data is drawn from federal sources, national sources, and data sets that really adhere to the most rigorous standards of data collection and analysis. So, like I said, we are an academic institution. We are researchers at heart. So having that academic rigor or that scientific rigor is one of the most important things that we kind of stand on. And the data sets that we pull from, we pull a lot from the American Community Survey, which comes from the US Census, the CDC, the EPA, the USDA. So all of these sources are objective, they're nonpartisan, and like I said, all of the analysis is the most rigorous that you can get. We want to be able to stand behind the data and the information that we present, and we want people and our users to trust that the data that they are seeing is accurate. And we have a pretty small team of just population health experts, policy experts, epidemiologists who work on the data, who analyze the data down to the district level. And so right now we have 1 year of data available on the dashboard. Whatever the most recent year of data that is available through the data set is what we provide right now on the site. But you heard it here first. Come June, come early June, we are already doing a data update or a data release and releasing another year of data for a good portion of these measures. So there'll be, I think there'll be 2021 data for a lot of our ACS measures. So a lot of these measures in the social and economic factors. So we'll have 2 years of data to look at as well. And so with that, I am just going to switch over to the website and give you guys a quick demo of what we provide. So like I said, our site is, excuse me, let me go to this. Our site is accessible at congressionaldistricthealthdashboard.org. All you have to do, or all you need, is a broadband connection, and you're able to access all of the information that we provide, all of our features for free. So like, we do not gatekeep anything. There's no paywall or account. You don't need to create an account to get any of the information that we have. So it was really important for us, again, that accessibility, that data availability. So we really, really pride ourselves on that. So this is the homepage. There's a couple ways to interact with the site and get into and kind of view the information that we provide. But I'm going to start looking at like a national view and then drilling down. So we can go to metric maps, and you're pulled up, or this metric selector that has all of the same metrics that I just presented on the previous slide listed here, and you can explore any of these measures and see the national map. So I'm going to start with rent burden, because that's always on top of mind. Just given what's happening with the pandemic and rental assistance programs. So you can see, at a glance, this map shows all of the 435 congressional districts for the US and their performance on the rent burden metric. So just kind of orienting you to the site, we have what we call the scale bar here, which represents the range of values for a particular metric. And across all of our measures, lighter colors indicate better outcomes and deeper colors indicate poorer outcomes. And so for a metric like rent burden, you want less of the residents in your district or your state spending more than 30% of their incomes on rent. So this side of the scale bar, those lower values, those lighter colors, that's more ideal. Whereas for a metric like high school completion rates, of course, you want more of your residents experience or completing high school or getting some sort of equivalent degree. So better outcomes would be on this side of the scale. And then this is the US average here. And then on the side, you can see, again, the measure that we're looking at, how we, or the metric that we're looking at, how we measure that metric, as well as the year of collection. And then you can kind of click here to get more information about the data source, all of that stuff. And so, like I said, it's, when I look at this map, the patterns are pretty clear. As we would expect, you see dark or pockets of dark purple or higher rent burden on the coasts. Those areas we know have higher rent burden. But what I'm also seeing is that, this southern corridor also has pretty high rent burden. And maybe that's not as obvious. Maybe we didn't realize that as much as we would for, the cities like New York or LA or San Francisco. So it's really useful for kind of digging into those patterns and seeing, what's happening in Colorado 3rd that, almost 48% of their residents are rent burdened. And so each one of the districts can be kind of clicked into, and you can see the name of the district, as well as the estimate or the value for that metric. And then you can click here to get zoomed into that measure. And so you're also able to zoom into the map this way, and I'll just kind of zoom into Florida. And the dashboard like I said, is not only useful for looking at like a national trend or like national patterns, but digging into what could be happening statewide. A lot of districts or a lot of representatives are kind of jockeying for funds and resources with other districts in their state. And so we want them to be able to find value, or, we've also seen a lot of journalists who write on a more state level beat in terms of whatever focus area that they're on. But they're looking at how districts within the state kind of compare to one another and perform against each other. So we can see here, Florida, and there's a lot of, there's some variation here, around Tampa, Orlando, but in Southern Florida, around Miami and Palm Beach and that area, the darkest shades of purple, we're seeing that like we have really, really a rent burden population, 64% in Florida 20, 63% in the 26th district, 61% in Florida 28. And just as like, I know this, but the most rent burden population is actually these three districts here in the US. And so you're able to zoom in on a state level this way, but you're also able to look at, you can type in your state or your congressional district in this field, and that'll pull up just Florida. So again, it's the same information, just like looking at it more specifically as opposed to having the full map available to you. You're also able to change metrics. And so I want to just explore uninsurance really quickly and go back to the national map. So we have what we call these breadcrumbs where you can kind of go back. And so now we're looking at the map of uninsured nationwide. And again, pretty easy to see those trends. It seems like the Northeast as well as the upper Midwest have the lowest rates of uninsurance, whereas this Southern corridor is experiencing the highest rates of uninsurance just at a glance. You see some dark shades in Texas and Oklahoma. And so I want to zoom into Oklahoma today. So I'm just going to type in Oklahoma. And we see a similar map to what we had just seen with Florida, but instead we have Oklahoma's data listed on the scale bar. So almost 17% of Oklahoma's residents are uninsured or lack health insurance or lack health access. And that's compared to the US average of 10%. But some districts have in Oklahoma, or some residents have 2% and some have 34%. And then I'm just, looking at the different districts in Oklahoma, you see a wide range of colors. You see this dark purple here in Oklahoma 2nd, but right next door, it's a very different situation in Oklahoma 5. And so again, just continuing to drill down, we can look at Oklahoma 2nd that has almost 22% uninsurance rates. And I can click into that district. And now we're only looking at the Oklahoma 2nd district. So that's what's really good about this dashboard, is that it kind of allows you to funnel the information based on what you're interested in, or based on the area that you're interested in, or that you're writing about, excuse me. So like I said, we can see how Oklahoma 2nd is doing. 22% of Oklahoma 2nd's residents are lacking health insurance compared to a US average of 10%. But I also want to show you this comparison value here. So the default on the website is to compare either states or districts to the US average, but you can just click this drop down and you can click Oklahoma average, or if we were in Florida and we were looking at Florida 21, we can compare to Florida's average. So that changes obviously depending on the state you're on. But so now when I switch to the Oklahoma average being the comparison value, we see, our sense making statement as well as the scale bar comparing Oklahoma 2nd now to the Oklahoma average. So 21.6% of Oklahoma 2nd residents lack health insurance compared to 16.6% of Oklahoma residents as a whole. So again, just different ways to look at the data. different comparisons to help you depending on, what you're focused on, and just to get, different context. Sometimes it's not useful to you to see that US average compared to my district, but sometimes it is useful. And so we want to kind of meet users wherever they are in what they do. And then finally, I want to, the second to last thing I want to just show you about, or show you today, is that we provide demographic breakdowns for about, I want to say 1/3 of our measures. So I think it's actually more at this point. But when we have these data available from our data source, not all of our metrics have demographic data available, so we can't provide that data. But where it is available, we will always provide demographic data. Of course, given that it meets our censorship criteria and all of that. But so for example, for a measure like uninsured, we have sex breakdowns, we have race ethnicity breakdowns, and we have age breakdowns. So you're able to not only get that geographic lens on various issues like uninsurance or like unemployment or walkability, you're also able to get that more health equity lens. And just see, how are different demographic groups, how do they compare to each other? Where are the gaps? What are the disparities that exist? And how can we use this information to not only, to target our policies, to target our outreach, but also to help us craft stories and learn about the different, or how different demographic groups might be vulnerable or might be impacted differently for various different challenges. Again, all of this information is useful in kind of helping us craft our story, develop our pitches, develop our hooks, and create more context to the storytelling that we're doing. And then the last thing I want to show you is just the district snapshot. So I am currently in New York 7. So I'll start with New York 7. And so this district snapshot gives you, there's a couple facets to the district snapshot. The first that I'm not going to go into for the sake of the demo, just because it's just too much to get into during 1 hour. But the first is this district facts tab, which has a lot of information about the demographics of every district. So the population demographics, the race ethnicity breakdowns, as well as information about that district's elected officials, the representatives, the senators, all of that. But what I want to focus on is the metrics overview, which is a quick, like 360-degree snapshot of how your district is doing across all of our measures. So you see all of the measures here listed alphabetically, as well as, so you see, the measure, the estimate or the value for that district. So for example, binge drinking, 19% of adults in New York 7 reported binge drinking. So it's really easy to see, okay, what is my value? I know a lot of us, or a lot of users of this site, need to get like quick facts for, talking points or whatever it is. And so this part of the website is really helpful in getting those quick talking points to, to give to our bosses, or give to our, our the people that we work with. And so we not only provide the New York estimate or the district estimate, we also provide a comparison to that US average and these like symbols that kind of signal to you whether or not the district is doing better than average, around the average, or worse than the average. So for example, with binge drinking, New York 7 is performing around the US average for that metric. And so you can hover over this statement to see, that the US average is 17.9%. So New York is around that at 19%. And you can see, the different symbology or the different symbols that we have, just to kind of be like a quick signal that like we're doing well, we can be doing better, we're doing about the same. And so I will go back to the slides, but I do want to also mention, in case it's relevant for this group, that all of our data is available for download for free. So you can download either the full CSV for all US congressional districts, all 435 districts for all of our measures, or if you're more focused on specific states, you can download these state files as well. And then moving back to the presentation, I just want to kind of close it with how journalists can really put the data into practice. And so like I've implied or spoken to, these data are, really useful in, and Margarita kind of spoke to this in the beginning. It's just useful for helping you uncover what the health challenges are in the communities that you write about or the regions that you write about. It's useful in just, getting ideas for stories. If I'm always focused on uninsurance, what's happening in uninsurance across the country, or what's happening in uninsurance across my state? Generating health stories. If you have a question that you're really interested in, what can the data say, or how can the data help you answer those questions about, specific districts or specific regions or states or whatever it is. And then additionally, if you already, if you're on like a specific beat, if you're already working on a specific article, use our data to help you kind of enrich your story, to create more context about what that challenge is that you're writing about. It's really, I think people like seeing data points. We're all very, we like seeing the hard numbers. And use our tool for that to really enrich the stories that you're writing, and ground your writing in objective, nonpartisan, trustworthy data. And then finally, I mentioned it a bit earlier, and Margarita also mentioned it, is we have another website called the City Health Dashboard that's accessible at cityhealthdashboard.com that provides much of the same data that we provide for the Congressional District Health Dashboard. We actually provide more data for this other site, but we provide our data not at the district level, but for over 900 US cities and growing. So we provide our data at the city level, but also down to the census tract or the neighborhood level for the 900 cities that we present on. So any city with a population of 50,000 and larger generally is included on this sister site that we have. But what we found in just talking with folks over the last 6 months or 5 months since we've launched the tool is that a lot of people can find value from both tools and use the information together and kind of collaborate that information to create just more understanding, a more comprehensive context of like what's happening. And so, yeah, like when reporting on, the healthcare landscape or policy or current events, like, there's so much about, I know I keep talking about uninsurance, but it's really on top of mind with the public health emergency winding down in May, the continuous enrollment provision having ended in March. So, states and districts and governments are really having to grapple with that, with the landscape that we're kind of left with as uninsurance changes in the next, months and years to come. And so it's sometimes important, of course, to get that regional or that national view, but how are people experiencing this challenge or this issue locally? What are the disparities or gaps that exist within cities or across cities? And again, you could just use these tools in tandem together to get a sense of regional and local challenges. And then in case anyone's not familiar with the City Health Dashboard, I've just kind of pulled out here 2 use cases or 2 uses of that tool. So the first is comparing health gaps across neighborhoods. I've kind of included a slide or a snapshot of the neighborhood level map of life expectancy for Columbus, Ohio, and highlighted these 3 neighborhoods that are less than 1 mile apart across, all 3. Yet residents living in these 3 neighborhoods have very different life expectancies that range from 60 to 80 to 68. And so this tool is really useful in identifying those gaps and where they are, but also digging into, why are these gaps appearing? What's happening on the ground that can be contributing to really different life expectancies? And then finally, the City Health Dashboard is a great tool for comparing your city to cities in other cities in your state, other cities with a similar population makeup, similar demographic breakdowns, similar sizes, and as well as cities in other regions. And so with that, I will end the formal presentation and I will open it up to any questions that have come into the chat.
Don't see any right now in the Q&A, so I'm going to throw out the first question.
Great.
Could you tell us about what's coming down the pike? When we spoke a few weeks ago, you mentioned that you are adding census tracts to
Yes.
the data in
Yes.
the CD dashboard. Could you tell us about that?
Yeah, so this is a really exciting update that we're launching. Like I said, I think it's the second week in June, June 10th, but don't quote me on that. And so we will be adding census tracts to this site. So we won't, so right now you're only able to see like statewide and then districts, but once we add census tracts, you'll be able to toggle into and see all of the different census tracts in your district and in your, or we won't have it for the state level, but you'll see all of the different census tracts in your district, again, providing more information to help you better understand what's happening locally. One of the strengths of the City Health Dashboard is the ability to dig really deep into local data and really understand what's happening for residents, within the neighborhood. And we wanted to provide that same level of granularity where we could for this tool, because it is so powerful. And it is, when as representatives or as journalists, it is useful to see what disparities may or may not exist within one district, and how can we allocate our resources or allocate our stories towards high need communities that really need our support in that way. So where that data is available in terms of the metrics and the data sets that we use, we will provide tracked level data come June. And then just to talk more about what's coming down the pike, we, like I said earlier, so right now we have 1 year of data available for all of our metrics, but in June with this data release, we will have for, I don't know the number offhand, but we will have 2 years of data available for a good portion of the measures as well. And so we plan to, as these data become available, release them onto the site. So you will be able to see multi-year data for the various measures where that data exists. We will provide multi-year data as it becomes available.
And journalists can sign up for updates about what you're adding.
Yes. Oh, that is a great comment. I will put in the chat. Can I write to everyone? Oh no, I can't. Host and panelists. I will just say, and maybe someone else can write it in the chat, but I highly suggest subscribing to our newsletter. And we do not spam. I think so right now our cadence for reaching out to folks is like, once a quarter, every other month. We're still kind of figuring out the cadence of how we're reaching out to people, but we don't want to spam people. We only want our communications and our correspondence to be really high value. But that being said, whenever we have a data release, like what's coming up in June, the first place where we update our users on that is that listserv. So I definitely suggest subscribing, and I will put that link in the chat for the host, and then we can send it out after the webinar.
Great, and I'll tweet that too, and I'll put it on the LinkedIn post I've shared. Okay, so 2 of our attendees have posted questions. So the first one is, does your data include data for incarcerated individuals in state and federal facilities?
So no, we do not have data on incarcerated individuals at the moment. Not to say that data won't exist in the future on our site. We just have not found a data set that where we can kind of use it, because because we provide data at a national level, the data sets that we pull from have to have all representation across the entire country, which limits the data sets that we can use, because we have to be able to compare, apples to apples in New York versus California versus Florida. And so it just might be that that data set does not exist for that topic. Not to say that like our team is not always researching, emerging data, innovative data sets where we can pull from it. We just don't have it at the moment for that topic.
Well, thank you for giving us that context. So the second question comes from attendee Mark Kamenzind, and I hope I'm pronouncing that right. And the question is, can you add more information on air quality, including ozone, NO2, SOx, and eventually should add tracking also for IAQs, such as for schools, CO2 monitoring, and indoor particles?
This is a great question, because it's one that we also are, thinking a lot about, just as climate change kind of gets worse, and as climate policy, sustainability, resilience becomes more front and center for different areas. So we have right now so we have air pollution PM 2.5 available on the website. So on our city site, we actually have a monthly measure of ozone pollution, where you can see, and we're this June we will be at, or this July, excuse me, we will be adding through 2021 for ozone, or through 2022, excuse me, for ozone. And I think we plan to add ozone for the Congressional District Health Dashboard in June. And so we have PM 2.5, we're gonna present ozone pollution. And then in terms of the other measures or issue areas that you mentioned, these are also on top of mind. We do some work with, the EPA brownfields communities, and they're doing a lot of stuff with like PFAS and NOx chemicals. So just because we don't have it now does not mean it's not a priority for us moving forward. And we actually are thinking through applying for different kinds of grants that will help us build out metrics that are more focused on, again, climate, sustainability, and more measures related to the to like air quality and that stuff that you just mentioned.
Samantha, could you tell us a little bit about the process that you and your team have in place to keep up with the data? And whether it's new things that are coming out, updating, how do you do that? It's a lot to keep up with, and
it's a lot. And we have an amazing team that are whip smart. And like I said, so the data sets that we pull from, like I said, the US Census, the CDC, National Vital Statistics System, most 99% of these data sets update on a yearly basis or an annual basis. That's something that we really care about, is having measures that are updated regularly. We don't want to just like show people 2010 data that's like not relevant to their community today. So as that data becomes available, our team kind of downloads it and like takes it, and we analyze it for down to the district level, which that data does not exist just like from the census. We have to kind of do our own analysis to be able to present that data at the district level. So that takes time. So we plan to do data updates like on a yearly basis, although we have, I guess, 2 updates this year. And then in terms of like a lot of the geography work, so before we launched the site, we had all of the census, all of the districts were based on the 2010 census. So we have a team of geospatial experts who were kind of reworking the districts and reworking the data based on the newly drawn districts and the newly drawn boundaries. So that takes a lot of thought work. And so as those things evolve, we plan to kind of meet the needs of that time and of those changes. And then we have a team that's, like I said, very smart, very nimble, and are really experts in this field. Like this, we were the first website to provide data like this, not only at the district level, but for the 118th Congress. So like now I think other sites are kind of doing it, but we were the first ones. So we plan to, remain at the cutting edge of geospatial data and of district level data.
I remember you sharing with me that you collect stories from entities that use your data. Could you tell us a little bit about whether cities or nonprofits or health agencies, state, regional, local, are sharing how they're using it to give context to health equity issues that they explore as a result of the disparities and the
Mhm.
that they're seeing.
Yeah, so and I can drop a link to this for our city site. I'll just pull it up. We have a whole bunch of what we call impact stories about local use cases. So for example, thinking about like equity, the one that comes to mind for me is this it's Rancho Cucamonga, California. The health or it's part of the mayor's office, but it's like they're kind of like health department. They were doing a quality of life survey just to understand the well-being, the opportunity of residents living in that city. And as city city officials, they kind of have a sense of like, okay, we know the racial makeup of our community, but we also know that like, if our community is, I'm just using these numbers as an example, 30% Hispanic, 20% Asian, but like we're not seeing that same representation in our government services, or in just like they're not engaging with government the same in a way that they should be. They're underserved by or underrepresented by government. And so this health office in Rancho used the data to see, I think they looked at life expectancy, children in poverty, and income inequality, and found that like these same communities that are really struggling in those areas were also the same communities that were ESL speakers and that identified as Hispanic, and were also not the ones that were being captured by this quality of life survey. So when they kind of saw that, they pivoted their strategy in trying in their implementation strategy of this survey. They hired community health workers or community liaisons that were of the community. They were leaders in the community. They spoke Spanish. They understood the sensitivities of that community. They understood messaging that resonated with that community in order to work. So like they put these people into the community, into those specific communities, to increase uptake in this survey. So help them translate marketing materials, translate the survey into Spanish, and not just do like Google Translate, like, and kind of put all of the English and then Google Translate spits out the Spanish. That's like not really, it's not, it doesn't really represent, the nuance that people speak. And so they hired these community health workers to do that sensitivity translation and do that nuance. And it ultimately, they saw like a 40% increase in the number of Spanish residents of their community that were reached through this survey. So there's things like that. Residents or users have found value in the dashboard for like implementing community health assessments or community health improvement plans. a community in East Point, Georgia, is in the process of thinking about their city strategic plan and how to ground that in equity and ground that specifically in health equity and really put a health and all policies framework in that strategic plan. And so they have come to the dashboard to really identify what are the areas and challenges that their city is facing, and what neighborhoods in particular or what demographic groups are feeling those challenges most acutely, and how can we ground our deliverables in making sure that we are hitting those or we are targeting those communications and or those communities intentionally with our policies, with our programs. So again, just tying things back to data. There's a community, a cross-sectoral group. This is the last one I'll mention because it's a lot of information, I know. But there's a national group called the Reinvestment Fund, which does a lot of just hands-on work in communities to reduce health equities through targeted investments. And their team in Grand Rapids came to the dashboard, looked at a whole bunch of our metrics, but kind of consistently across all of the metrics that they looked at, these 17 census tracts or neighborhoods were continuously performing poorly compared to other neighborhoods in the city. And so using that information, they, I think they allocated at this point more than 30% of the state of Michigan's low-income housing tax credits towards these 17 communities. They received like a $500,000 grant from Spectrum Health, which is a local health center, for those communities. They partnered with Link Up, which is an affordable housing organization, to build more affordable housing units in those same neighborhoods. And not only are they building the affordable housing units in those neighborhoods that they identified from the dashboard, they're also employing residents from those neighborhoods to actually build the housing units. So it's really a multi-pronged approach, but they're grounding all of these like strategic investment decisions in the data that they have found from the dashboard into those communities that they know have the greatest need. So that's just a couple. And I will also put the link or give Catherine the link to that part of the site that you can visit and see our kind of depository and our collection of impact stories in case it's of interest.
That's great, and I'll also share that too when you post it. We've got a third question also by attendee Mark Kamenzind. And here's a question: COVID seems to be slowing down, but millions have long COVID, perhaps for decades, and that is a huge health burden. Can you track long COVID per district? And I'm guessing Mark is with an organization, a nonprofit or a policy advocacy group, because he also says we are seeking to pass Care for Long COVID Act, HR 1616 and Senate 801, to get more doctors trained and improve COVID tracking in more centers of excellence, which I'm assuming are about COVID. So if you could shed some light on that, that'd be great.
Yeah, so this is something that we're thinking about. So right now we have a measure called the local COVID, or the COVID local risk index, excuse me, that we developed in June of 2020 for residents or for users to see what risk looked like in their city. And we have that measure also for the Congressional District Health Dashboard. But as you said, COVID's winding down. We're thinking about, is that measure relevant anymore? And so we're thinking about actually sunsetting that measure. But we know that long COVID is, a big challenge for folks. That data does not exist yet. Again, at that wide level that we need it to be. It doesn't exist nationally. And the tracking for long COVID, there's just not that infrastructure in place like there is for COVID tests or hospitalizations or any of that. That being said, we do, one of the PIs on our project is leading, I think I don't want to speak out of turn, but I think it's, if not the largest, one of the largest long COVID studies in the nation. And I know that they're kind of in the data collection process, and these things take time, but I would imagine that they plan to release their findings at some point soon. And that's just that project or that study is called Recover COVID. And they're specifically looking at long COVID and long COVID outcomes. So I would suggest checking that out. It's not what we provide, but it at least is information that could help you with the work that you're doing.
Are you getting emails from journalists suggesting data sets, or people who have journalists who have a wish list of what measures they want to see? Could you talk to us about that?
Yeah, we get emails all the time from journalists, from whoever, about measures that they want to see included on the site. We have our own wish list, and we're always kind of adding to our wish list of measures that we want. I have my own wish list, like someone mentioned incarceration. That's something that like I would love to see on the dashboard. My colleague is very focused on, maternal and infant health, asthma. So what we have tried to do is, like I said, so we have this list of 36 measures, which we think is that good 360-degree view of traditional health measures that you would expect from a health website, but also really placing an equal emphasis on the SDOH. And so there's always that balance of, more measures, more data, more everything, but we want it to be curated. We don't just want to present data for data's sake. We want it to be, because sometimes when I've looked at sites that have just so much data available and you don't know where to start. So we don't want it to be overwhelming with the data that we provide. We want it to be curated. And so there's always going to be that balance of, do we show this? Do we not show this, even though we really want to show it? And beyond that, just does the data exist? Does it exist for all of the locations that we represent? And does it exist at the academic rigor that we need it to? Again, I talked about trustworthiness of the data. That is like the most important thing to us. So there's always that dance that we do. But we're in a process right now. Like I mentioned, we might be sunsetting the COVID index. Just because a measure is on the site now doesn't mean it's always going to be there. And just because a measure is not on the site doesn't mean it won't be there. So, just this past year, we added firearm homicides and suicides to the dashboard. And so in doing that, we replaced a measure of violent crime that just wasn't as useful or actionable as specific as the data that we now provide with firearm homicides and suicides. So we're always thinking about this and kind of weighing all of the options. And then just another note about measures. So in public health, we see a measure that is 3 years old and we think, oh, that's pretty recent. But a lot of people who don't work in the public health space don't understand that like a 3-year data lag is they see that and they're like, oh, that's so old, that's outdated. They don't realize that that's actually not that old, just given all of the data collection and analysis and validation that has to go into it for it to even be presented publicly. But the pandemic, we were used to seeing data updated on an hourly basis, if not like a daily basis. And so we're also innovating and researching potential metrics that are more timely and bringing those to the dashboard, and really weighing, sometimes you have to weigh the pros and cons of, okay, if we're having a timely measure, what's that other thing that has to give? And are we okay with those trade-offs? And so we are exploring ways to bring more timely measures to both sites.
Could you tell us a little bit, and this may be a really broad question, but I thought about asking it anyway. How do you um, ensure, the trustworthiness of the data? How do you all, uh, measure that, I guess? And if you could shed some light on your process for that, that'd be great.
Yeah, so that really is uh so that's one of the reasons why we only pull from national data sets. So some of our data sets are proprietary in that we have to pay for them, or we have like a DUA with them, but those are, one-off data sets. And again, we do a whole, very extensive round of validation about that. And in terms of but thinking about our national data sets, like I said, the CDC, the NIH, we only pull data sets or data from sources that we know we can trust. We trust the CDC, we trust the NIH, we trust the EPA. And so as long as we can kind of pass that litmus test with that, we know we can trust the data that we provide. That being said, for all of the data that gets put on our site, like I said, we go through a very extensive round of validation to make sure that we can stand behind the numbers that we see. We're also, trying to we're trying to replicate the numbers that we collect and make sure that other sources are getting the same thing, or that other data analysts are getting the same numbers. And again, just another note about accuracy and trustworthiness. So when there is data that is either too small to be reported on, or too small, like there are too small, the numbers are just too small.
The
Where
sample
like
sizes are
the
too
sample
small.
size is too small. Exactly. I can't think right now. It's afternoon on a Friday. When there just are not enough events, we have a pretty strict, a stricter censorship criteria or suppression criteria where we won't put that data on the site. So not only if there's just too few events where like privacy could be implicated, those data do not go on the site. If the sample size is too small and the estimate is just too unstable, we do not present data for that place. So those are things that those are checks that we have, where we kind of say we rather not present the data than present data that could be false or could be, or just could be extrapolated to mean more than it actually does when like those margins of error are too high. So that's also extremely important to us, and a pillar that we stand on, that that if we're not presenting data, it's because there's just not enough there. But if we are presenting data, we can stand by it, and we document all of those decisions in our FAQ and in our technical documentation as well.
A lot of our members are working newsrooms, about 2/3 of them, and about a third of us are, and I include myself on that because I'm an independent journalist in Dallas. What how can we reach out to you to put a training together, if maybe one of our members wants their newsroom to do it, or um, can you talk to us a little bit about that? Is that something that you do?
Yes, I love to do or our whole team loves to do trainings. We do webinars like this, multiple times a week, it feels like, where we're kind of talking about walking people through the website, the measures that we provide, answering questions. So I would just email me at just samantha.breslin@nyulangone.com, and I'm sure Margarita or Catherine can send around my email. But please reach out to me. Like I said, we can set something up that's more specific to your area or your location, or set something up that's more specific to the topic area or your beat. And even if it's not like a formal presentation like this, just a conversation, happy to do that.
So we've come up on the 2-minute warning, and my last question is, what is one of the more memorable questions that you have gotten in your trainings about
Ooh,
the data?
on the spot. I don't know what the most memorable question is, but we just get a lot of great questions about like thinking through the various just the geographic questions, like the geographic potential problems, challenges that come with providing this data. Like I said, we're the first tool that has provided data for the 118 congressional districts that are kind of bound to the 2020 census. And I'm just always shocked at how knowledgeable non-geospatial people are about the intricacies of presenting data on those kinds of in these new geographies. This is a part of like data that I had no idea really existed prior to being in this role. And so I always just am so fascinated by how non-geospatial experts are, how knowledgeable they are.
Well, thanks for that. And we've come to the end of the webinar. Samantha, thank you for making time for us today. We really appreciate that, and for explaining everything that you did, and also for being available to answer questions. We will share your email address, and thank you to everybody who tuned in today to this AHCJ webinar. It will be available on our website in a few hours. So please, if you couldn't join or had to leave early, you can watch it there, and we'll provide these links that you have shared on Twitter and LinkedIn. And so thanks again, and have a great weekend. And I'm sure I'll be giving you a call or sending you an email in the future. So thanks a
Great,
lot.
please do.